webinar series on standard treatment guidelines has been going on for more than 3 years. This is National Health Systems Resource Center in collaboration with Delhi Society for Promotion of Rational Use of Drugs. And we are honored to have the honorary president of DSPRD with us, Dr. Sangeeta Sharma with us. And she is herself going to be a speaker today. And there's a very interesting topic that is outlined for us, which is pharmacology and medication-related issues in management of heat stroke. But before that, we have Dr. Devendu Bhushan from AIIMS Patna, who will be talking about heat illness and heat stroke, and also action at primary care. What can you do for early recognition, rehydration, and what should be the referral triggers? Dr. Bhushan is himself an expert and additional professor in emergency medicine. So for those who have, what I see is in the list of participants, we have some very regular participants who have been with us. But those who are new or may have joined this year, this is the 4th year running. I must advise you that there is a pre-test and a post-test after the session is completed. And if you complete both the tests successfully, then there's a digital certificate that is issued to all the successful participants. This STG series has been on for 3.5 years, as I just mentioned, and more than 12,000 healthcare professionals, specialists, super specialists, medical officers, CHOs, nurses, and anyone who's interested in standard treatment guidelines has been joining us. And we thank all the people who have joined us in this journey till now and our loyal participants because they've seen value. I must share with you, Dr. Sangeeta, that there was a demand from the advisors in NHSRC also. They said that you are organizing such a wonderful series and somehow we've not been onboarded. So I have shared it with the advisors as well and ED as well. And they will be joining our sessions from wherever they are right now. So the STG webinar series has taken on a life of its own and a definite identity. And Dr. Ranjit, who's here, who's anchoring, will tell us about how many people have already received the certificates. One important thing that needs to be highlighted, why are we holding these sessions on standard treatment guidelines? It is because quality of care improves when we standardize processes, standardize treatment, and everyone is on an evidence-based platform. So we need to integrate, we need to understand the resources and the constraints therein and understand why variability takes place and how do we handle variability, standardize the steps, standardize the processes, standardize the treatment. With this, I'll hand you over to Dr. Sangeeta to take it forward and then to Dr. Ranjit to introduce our esteemed faculty.
I think we can go ahead. Dr. Devendu is already here with us since 3 o'clock. He's been traveling, so kind of him. He was traveling, but still he adjusted his program for us. Thank you, Dr. Devendu, for joining us today.
Thank you, ma'am.
Ranjit, you can introduce him and then he can proceed with this session.
Thank you, sir. Thank you, ma'am. This is the 42nd STG webinar series of the 4th webinar series of STG. I welcome our first speaker, Dr. Devendu Bhushan sir. He is a medical graduate with MD in internal medicine. He is currently working as an additional professor and head of the Department of Emergency Medicine, AIIMS Patna. He is qualified with a postgraduate diploma in hospital management from, I think, MIHFW and PGC.
It is NIHFW.
uh,
NIHFW. It is like
NHFW.
maybe.
He is also
Yes.
the president of SIMI Bihar. He is a certified BLS and ACLS instructor. He is having more than 50 publications in Index Journal and also more than 20 years of practicing experience. I request our speaker to continue with his session on heat illness. Thank you, sir.
Dr. Devendu, before you start, just
Yes.
I wanted to mention we have a mixed group here, nurses, doctors, quality managers from all levels of healthcare from all over India.
Yes.
Represent majority are from government sector, but we have few tertiary care participants from private sector as well.
Okay. Thank you, ma'am. Can I start now?
Please take it away.
Yes.
Yes,
Thank you, sir. So first of all, I am thankful to Sangeeta ma'am and whole NHS RC team and Dr. Ranjit too, who given me this chance to interact with all of you in this month of June, where some of the areas in the country is really struggling with the sun. In fact, in my state, Bihar में भी अभी लगभग 40 degree temperature and everything is boiling. So this is very apt topic that we should know. And या फिर मैं एक वैसे ही बताएं कि जाने अनजाने ऐसी कई बार चीज़ें आती हैं जो हीट स्ट्रोक जैसी चीज़ें होती हैं, हीट एग्जॉशन होता है और हम लोगों को पता ही नहीं होता है. सो लेट्स सी कि हीट से रिलेटेड क्या क्या चीज़ें हो सकती हैं, हाउ टू अवेयर आवरसेल्व्स कि वैसी चीज़ें ना हो. कुछ हाई रिस्क ग्रुप हैं लाइक एल्डरली, बच्चे, जिनमें ऐसी प्रॉब्लम होती है और हम लोग सोचते हैं कुछ और हुआ होगा. तो लेट्स सी. कैन आई प्रेजेंट नाउ? कैन आई शेयर माय स्लाइड्स?
Please. And if you need the NHSRC team to support you, they can help you.
Sure, sir. Thanks.
Open in a window, then if you have your PowerPoint open, you can open
Yes,
this
yes.
in window also. Just now you tried, है ना?
Yes, ma'am. Is this visible?
Yes, your screen is visible, but this is not a PowerPoint.
Ma'am, this is a PowerPoint?
No.
Okay.
This is you have opened the internet Google file. हाँ अभी आ गया था. Yes.
I'm able to see the slides. Your first slide and now introduction. Yes.
Is it okay, ma'am?
Yeah, this is okay.
It's all visible, sir.
Yeah. Thank you. So, heat-related illnesses is a continuum of diseases due to increased body temperature and caused by the environmental conditions or exertion. So, it can be जो हीट इन्वायरमेंटल हीट है, जब समर के सीजन आया तब तो हीट स्ट्रोक हो ही सकता है. वन अनदर थिंग विच वी आर इनकाउंटरिंग इन आवर कैजुअलिटी आल्सो कि कभी कभी एक्सर्शन की वजह से भी आते हैं, बट वी नॉट एडवाइज टू डू. जैसे कि कई बार पुलिस की भर्ती होती है. अभी हमारे पास लास्ट मंथ 2 पेशेंट ऐसे आए जो पुलिस की भर्ती के लिए दौड़ाए, मतलब उनको फिजिकल एग्जामिनेशन में उनको रनिंग करने के लिए बोला जा रहा था, and they extremely worked hard and they fatigued and they in fact one of them had seizure after the falling down. तो ये सब भी manifestations हो सकती हैं जो कि exertion की वजह से होती है. Like older adults and the people in the poor socio-economic conditions are more susceptible during the heat waves. Children are also a high risk group. कभी कभी वो क्या करते हैं कि खेलते रहते हैं, चिल्ड्रंस का क्या है कि उनको खेलने के लिए मिल जाए तो वो उनको गर्मी सर्दी कुछ दिखाई नहीं देता है, दे जस्ट कीप ऑन प्लेइंग द थिंग्स, एंड उनको पानी भी कम पीते हैं, एंड दे सफर ड्यू टू हीट exhaustion और हीट स्ट्रोक इवन. India recorded around 84 heat stroke deaths in around year 2025. Integrated Diseases Surveillance Program at National Center of Disease Control under the Ministry of Health and Family Welfare, Government of India, collects the reports and of morbidity and mortality data of health-related illness from heat vulnerable states since 2015. So this is a focus of area since then. It around total around 4,000 deaths occur in year 2015 to 2019. So in India, when we called it heat wave, when the temperature crosses 40 degrees centigrade in the plains or 37 degrees centigrade in the coastal stations, or at least 30 degrees centigrade in hilly regions, or the following criteria can be used to declare heat wave. Like if it is normal, say अगर उसका temperature variation 4.5 to 6.4 centigrade हो जाता है, then it is called heat wave. Severe heat wave is labeled when it is crosses more than 6, the difference is more than 6.4 centigrade. Based on the actual maximum temperature, if the heat wave crosses around 45 degrees centigrade, then it is called heat wave, severe heat wave. If it is the temperature crosses more than 46 degrees centigrade. So this is very much clear. So whenever we claim it is a heat stroke in India, in the plains, the environmental temperature should cross around 40 degrees centigrade. This is about the environmental heat stroke. It is not about the exertional heat stroke. A little bit about the physiology of this heat transfer in our body. Our body conduct heat by 4 mechanisms, like conduction, where the direct transfer by the physical contact. 2% of the body heat loss occur due to this. Air is a poor conductor and water is a good conductor. 25%, 25 times better conductor than air. So when anybody have fever, तो हम लोग क्या करते हैं कि उसको पट्टी लगाते हैं, तो वो कंडक्शन से उसको एब्जॉर्ब, उसका कंडक्शन से हीट लॉस होता है. Convection, heat loss to air or water molecules circulating around the body, varies with the wind velocity. It loose clothing maximize the convective heat loss. So what we advise in during the heat कि भाई सूती कपड़े पहने, ढीले कपड़े पहने. So all these are the things where the heat can dissipate through the convection. Radiation, like heat transfer via the electromagnetic waves from the warmer object to the colder object. 65% of the heat loss in cool or ambient environment less than 35 degrees centigrade, it happens due to radiation. Evaporation, heat loss by the vaporization of the water or sweat. 1 ml of the sweat evaporation causes losing of 0.58 calories. Dominant mechanism during the exercise and heat loss is a hot in a hot environment, the evaporation. And when the ambient temperature crosses 35 degrees centigrade, body can no longer radiate heat, and it becomes dependent on the evaporation for heat transfer. So where the radiation blocks, the evaporation can take place. But as the humidity increases, the potential for evaporative heat loss decreases. So if the humidity अगर ज़्यादा हो जाएगी तो evaporation कम हो जाएगा. Little bit about the thermoregulation in our body. So we have senses in the periphery and the central. Thermosensitive neurons in the preoptic anterior hypothalamus activates when the body blood temperature exceeds the set point. Central integrative areas like CNS penetrate the sensory data and instruct the thermoregulatory factors to respond appropriately. So it is mainly controlled by the hypothalamus. Sweating and the peripheral vasodilatations are the primary heat loss mechanism for the heat-related illnesses. Increasing skin blood flow maximizes the convection and radiation. So a little bit about the acclimatization. If somebody comes from a hilly area or a area where the heat is not so much, and they come to the hotter area, so what happens due to in the acclimatization? The earlier onset of the sweating at the lower core temperature by the lowering the thermal set point in the hypothalamus. So आपका hypothalamus, the person's hypothalamus is set at the lower at the higher set point. Now it is decreased. Lower the there is an increase in the sweat volume. In the day 3 to 5, the increase in the sweat volume. Earlier onset of the sweating, it lowered the sweat sodium concentration because of hormone aldosterone secretion, which is boosted, resulting in sodium conservation by the increased reabsorption from the sweat, and plasma volume expands, and heart rate decreases for any given heat load. Exercise tolerance improves in the 14 days. So around it takes 2 weeks times to acclimatize to a hot environment. Who are at the who are those who are at the high risk groups? So elderly. What इसमें मैं अपना input मतलब I will invite inputs from all of you, but see what I have seen कि जो elderly होते हैं, they have tendency to live in an environment of AC free. मतलब टेम्परेचर बाहर का टेम्परेचर 40 भी होगा तो भी कहेंगे कि नहीं पंखे में ही ठीक है. They do not feel good in the AC environment somehow. So this tendency, their behavioral changes, they also make them vulnerable for the heat stroke. Fewer heat activated sweat glands होती हैं इनकी, decreased cardiac output, reduced vasodilatory response, and they have most of the elderlies are on many medications also, like diuretics, anticholinergics, beta blocker. Those medications also make them susceptible for heat stroke. Children's higher surface area to mass ratio hota hai, so lower the sweat rate per gland. They can present with more severe neurological symptoms. They can present with seizure. Few days back in our society, one kid of around 10-year kid, he suffered heat in the pool. He suffered unconsciousness, and he was near the pool. He drawn there, and somebody took him out, and he resuscitated him. So all these can happen in the children's. Athletes or laborer, those who are work whole day in the sun, they are mostly susceptible to these. So they have environmental heat stroke also, and their activity is like that. They have to exert. So exertional heat stroke. So both of them combined, and they can get the heat injuries. Chronically ill patients like diabetes, cardiac conditions, hypertension, psychiatric illnesses, or autonomic disorder, which exaggerate the heat response to heat. Medications we have discussed, and socio-economic vulnerability, poor access to cooling, water, or healthcare services. All this make the susceptible persons. We have seen that these are the risk factors: fever, dehydration factor, and the physiological factors like fever, dehydration, chronic illness, uncontrolled diabetes, uncontrolled hypertension, and sleep deprivation. All these are the patient-related factors which increases the vulnerability to the heat stroke. Physiological factors like older age, young children, athletes, alcoholics, autonomic disorders, psychiatric conditions, hyperthyroidism, extensive skin diseases like systemic scleroderma, heavy clothing and equipments. Heavy clothing along with the nylon ki clothing, the type of clothing also matters. Decreased vasodilatory response or fewer heat activated sweat glands. Medications that increases the risk of heat stroke, like we have discussed, like beta blocker, calcium channel blocker, diuretics, alpha agonist. So these are the medications which mostly the elderly are using. After 50s, every person is taking one or the other drugs. So beta blockers. Dr. Ranjit, is there anything? Am I audible, Dr. Ranjit?
Yes, sir. Yes, sir.
Okay. So beta blocker and CCBs, calcium channel blocker, decreases the cardiovascular response to heat, and they reduces the peripheral blood flow and ability to sweat. Diuretics leads to volume depletion and decreases cardiac output. CNS and psychiatric medications like anticholinergics, antihistamines, and benzodiazepines. These deplete the central store of dopamine, which interfere with the hypothalamic thermoregulatory center. Stimulants and illicits like cocaine, amphetamine, LSD, sympathomimetics. These drugs causes the cutaneous vasoconstriction and inhibit sweating. They increases muscle activity, also leads to the heat production, disrupt function of endogenous endorphins and adrenocorticotropic hormone that are involved in the heat adaptation mechanisms. All these another drugs like ethanol, heroin, laxative, thyroid agonist, inhaled anesthetics, all these are make the person vulnerable. So this is the spectrum of heat related illness. You can see from green to red, like milia rubra, heat cramps, heat edema, heat syncope, heat exhaustion. And at last, the heat stroke, when the core body temperature rises beyond the 40 degrees centigrade or 104 and 104 Fahrenheit, CNS dysfunction and requires immediate cooling. And the whole what we can call short circuiting हो जाती है हमारे बॉडी में, मतलब हमारा बॉडी जो thermoregulatory system which we have talked about, that totally disrupts. So let's come to the minor heat related illnesses. So मिलिया रुब्रा, that जो हम लोग कहते हैं कि गर्मी के दाने हो गए हैं. What is this? These are the acute inflammatory skin disorder caused by blockage of sweat gland, forced by macerated stratum corneum with secondary staphylococcal infection. They are intensely pruritic, macular erythematous rash confined to clothed area. The affected area is often completely anhydrotic. What we can do, we can put the topical steroids or like hydrocortisone 2.5 percentage or triamcinolone 0.1 percentage twice a day for 1 to 2 weeks. Prevention is definitely better than this. So for prevention, we have to advise to wear loose clothes, light clothes, light color clothes, and clean clothes. Avoid routine use of talcum or baby powder because they block the sweat glands. The gentle exfoliation or to remove the debris from eccrine ducts. Heat cramps, painful involuntary spasmodic contractions of skeletal muscles, usually calves, thighs, shoulder, and they are fatigued by heavy work or prolonged exercise. These kind of patient we mostly encounter in OPD कि हमारे घुटनों के नीचे हमारे काफ्स में बहुत दर्द होता है, अकड़न होती है, पूरी रात नींद नहीं आती है. So the most important things are this usually happens in the laborer worker because they work day for about 8-9 hours in the sunny period, or otherwise also they can cause the exertional heat cramps if they are working hard. So it occurs when the large amount of sweats are lost and replaced with water and hypotonic fluid. पानी पानी पिए जा रहे हैं लेकिन मिनरल्स नहीं मिल रहा है उसको, लीडिंग टू द हाइपोनेट्रीमिया. दैट इज व्हाई इट इज इंपॉर्टेंट. मैं आई विल टॉक लेटर ऑन अबाउट द ORS, बट हियर आई आल्सो एम्फसाइज कि अगर आप, ये बहुत छोटी सी चीज़ है, अगर कोई वर्कर है जिसको जो आपके यहाँ काम करता है या फिर आपके नियर बाय में काम करता है, तो कम से कम उसको ये एडवाइस करें कि भैया तुम पानी लेते रहो, पानी के साथ में कुछ नहीं तो नमक चीनी का घोल लेते रहो. ORS is the simplest thing which is available free of cost at various PHC levels. So these are the things where the small intervention can save the lives. When usually occurs during the first day of the work in a hot environment, common in athlete and the manual laborers. Investigations which we can do the electrolytes and rhabdomyolysis is rare, but it can occur अगर आपको बहुत जल्दी में हुआ है. The person which I am talking about कि दो person जो पुलिस में भर्ती होने के लिए आए थे और हमारे पास आए, they have rhabdomyolysis and multi organ failure. So these things can happen. Treatment: fluid and salt replacement, rest in the cool environment. Mild, if it is mild, then ORS and electrolyte solutions are very good. Salt tablets दे दीजिए आप उन्हें, और सिवियर अगर हो रहा है तो हमें उनको IV saline देना पड़ेगा. Heat edema, it is the pathophysiology behind this is hydrostatic pressure, cutaneous vasodilation along with the orthostatic pulling. This all causes the vascular leak, interstitial fluid in the lower extremities, because the laborer work, mostly the person works in the standing position, so there the edema occurs in the dependent part of the limbs. Aldosterone and ADH rises in response to the heat stress, contributes to the mild edema. So person will have swelling in the feet and the ankle, usually minimal and not accompanied by any significant functional impairment. often resolve after several days of acclimatization. So जैसे जैसे ठंड का मौसम आएगा, they will cover. Differential diagnosis: cardiac congestive cardiac failure, liver diseases or nephrosis, lower extremity infections, and deep vein thrombosis. Management: then it is a self-limiting condition, so simply leg elevation and or thigh elevation is recommended. Diuretics are not effective. They can give momentarily benefit, but ultimately it can worse. Diuretics can worse the condition. So please don't go with the diuretics, and no pharmacological per se therapy is advised. So it is a symptomatic therapy and it will recover by itself. Heat syncope: in response to hot, humid environment, peripheral vasodilatation and volume loss occurs. This inadequate central venous return and decreased cardiac output and cerebral perfusion that ultimately causes the syncopal attack. So the heat syncope can be precipitated by underlying metabolic or cardiac disorders. Cardiac monitoring like ECG and hemoglobin determination are warranted in all cases. Place the person in the horizontal position. Do the cardiac monitoring, ECG to rule out cardiac disease. Older patients may require admission or cardiac or neurological evaluation because not only the heat syncope, that now in elderly we have to think, we have a long list of differential diagnosis from complete heart block to the vasovagal syncope to the autonomic failure. So all these can lead to them syncope. So the elderly may require admission. Advise these patients to move around often, flex leg muscles with standing and sit lie if prodromal symptoms occur. Now heat exhaustion or heat stress. So this is the spectrum of the disease which we encounter in our emergency too. So a clinical syndrome of volume depletion occurs under the conditions of heat stress, does not meet the criteria of heat stroke. Body temperature is usually normal or minimally elevated, usually 104 Fahrenheit. So water depletion occurs in the elderly and persons working in hot environment with inadequate water intake, excessive sweating or associated with hypernatremia. And along with this, salt depletion, non-acclimatized individual who replace fluid loss, sweat with hypotonic fluids and result in hyponatremia. Heat exhaustion symptoms are confusion, headache, dizziness and fainting, because these patients may not present with a fever. So the boy which fallen down in our nearby pool was had just dizziness and fainting. So we have to think about the heat related illnesses when there is the background of heat, fatigue, dark urine, because the person do not drink water, adequate amount of water, the urine become dark yellow. Muscle or abdominal cramps, pale skin and profuse sweating, nausea, vomiting or tachycardia. So we have to be really, we have to search it out कि इस कंडीशन में इस व्यक्ति को हीट एग्जॉशन हो सकता है. So what management we should do? Move out of the direct sunlight into the cool or the shady place. So we have to increase the awareness to the people कि भाई अगर आप मेहनत का काम करना ही करना है, आपको धूप में काम करना ही करना है, तो कोई बात नहीं, आप कीजिए, लेकिन एडिक्वेट अमाउंट में पानी लीजिए और बीच बीच में ठंडी जगह पे जाते रहिए. What we all advise कि भाई पानी के छींटे मुंह पे मारते रहिए, सूती कपड़े पहनिए. So lay the patient flat and elevate the feet if dizzy or fainted. Hydrate with the ORS and water. Remove excessive clothing. Wet the patient and fan them. Place wet cloths on forehead, head or neck. Monitor temperature continuously. Heat stress with an elevated temperature can progress to heat stroke after is removed from the hot environment. So patient should not be prematurely labeled as having as having heat stress without observation and reassessment. IV normal saline is significant if for the significant volume or the electrolyte depletion we can give. So we have discussed that dress smartly, light-weighted, light-colored and loose-fitting clothing are important, and wide-brimmed hat, कुछ ऊपर लगना चाहिए. जैसे लेबरर्स की बात करते हैं, वहाँ वो लोग हेड कहाँ से लेकर आएंगे, लेकिन जो कहते हैं ना सर पे गमछा बांध लेना, हमारे बिहार में बोलते हैं, यूपी में भी बोलते हैं, गमछा बांध के काम करना, जिससे कि डायरेक्ट हीट जो है वो सर पे ना लगे. That is also as good as a hat. Stay hydrated. Drink plenty of water, fruit juice, vegetable juice throughout the day. सो सिंपली वाटर और फ्रूट जूस और ओआरएस, जैसे बताया, शिकंजी हुआ, उसमें कोई बहुत ज़्यादा नहीं है, नमक डाला, चीनी डाला, नींबू डाला और शिकंजी बन गई. या फिर सत्तू हो गया. सत्तू भी एक बहुत अच्छा ड्रिंक है जो हाइड्रेटेड रखते हैं. सन प्रोटेक्शन, यूज ऑफ सनस्क्रीन विद एसपीएफ ऑफ 30 और मोर व्हेन आउटडोर्स. एंड अवॉइड डिहाइड्रेटर्स, लाइक जो कभी कभी जिसको चाय पीने का बहुत शौक होता है, they should be aware of this, कि ultimately these alcohol or caffeine जो thing है, they are the diuretics, they causes the excessive fluid loss and can worsen the heat exhaustion. So this is a table from Internalis Emergency Medicine. Here we can see in heat cramps, the person will have muscle cramps, normal to mildly elevated temperature and sweating. Heat stress, person will have symptoms as in the heat cramps plus normal to elevated temperature. So in the heat stress, the person can have the normal temperature too, but the person will have nausea, vomiting, headache, malaise, dizziness, or orthostatic hypotension. So they are about to land up in the emergency. So we have to really look for it. And heat stroke, like symptoms seen in the heat stress plus elevated temperature. Now these people will have that high temperature. So this can be differential diagnosis of any febrile illness, like it can be differential diagnosis of dengue syndrome at this time, dengue ho gaya, malaria ho gaya, leptospira ho gaya, meningitis ho gayi. So these can be the differential diagnosis. Neurological abnormalities like inappropriate behavior, confusion, delirium, ataxia, coma, seizures, all these can happen in the heat stroke. Anhidrosis or sweating. So anhidrosis marks the heat stroke because the our thermoregulation खराब हो जाता है हमारा, और हम स्वेट भी नहीं करते. Now come to the major heat related illness like heat stroke. So heat stroke where the core body temperature crosses more than 104 Fahrenheit. And along with this, the person has altered mental status. Average 3 to 4 patients come to daily in our emergency with this thing. Temperature more than 104 and altered mental status. These can be a feature of meningitis. These can be a feature of malaria. This can be a feature of dengue syndrome. So, but we have to rule out all others. And if uh, if we are thinking that the person has heat stroke, has the precipitating factors. Last year in year 24, we have reported around 65 people of heat exhaustion and the heat stroke. And of these, the major patients are from in the elderly background. What I have observed that those patients are living in the top floors or the where in the room where they are not using air conditions. So those environment make them vulnerable for the heat stroke. These conditions represent failure of thermoregulatory hemostasis. Risk of morbidity, mortality is directly associated with the duration of hyperthermia. And every minute counts when we talk about the life. So heat stroke can be of two types: classical non-exertional environmental or exertional. The classical one occurs during the period of high environmental heat stress and no strenuous activity involved, elderly, very young, or chronically ill patients. Gradual onset over the hours and the days, and anhidrosis is the common symptom. Strenuous physical activity, young, healthy athlete or laborers. Rapid onset, sweating often presents, and the lactic acidosis is common. Which I have discussed कि हमारे यहाँ दो लोग पुलिस वाले लोग आए थे बेचारे, but one of them we could have saved and one we could not saved. The person whom we could have not saved has critically presented in the shock and the altered mental status. He has all the feature of rhabdomyolysis, AKI, and multi-organ failure. He survived for only 12 hours. So this is very deadly features. So what are the common other features? Along with the altered mental states or the confusion, the person can have throbbing headache, nausea, dizziness, body temperature more than 40 degrees Celsius, hot, red and dry and moist, dry skin, mostly dry. Moist can be happen, but it is almost dry. Rapid and the strong pulse, shallow breathing, fainting and loss of consciousness. CNS manifestation may be generalized or the localized one like impaired judgment, inappropriate behavior, hallucinations, ataxia as cerebellum is very sensitive to heat. Seizures, delirium, confusion, hallucinations, decorticate or decerebrate posturing, hemiplegia or coma. So you can see there are various things which we can be confused with. Suppose somebody present with a seizure, so we can label that it is a seizure patient. No, we have to look it. Is the environment is hot or ambient? If it is hot, if there is a precipitating causes, do not forget to rule out heat stroke, because the decrease you have to make the person's temperature lower down to save the life. But lab investigations help us. Random blood sugar, check for the hypoglycemia, complete blood count, PT, APTT, electrolyte, full blood counts, LFT, liver injury can occur, urine and creatinine level, because rhabdomyolysis can cause acute kidney injury, and per se the dehydration can cause the prerenal azotemia. This and serum CPK level, calcium and the phosphorus detect the rhabdomyolysis, hypocalcemia and the hyperphosphatemia. Urine dipstick and urine analysis to look for myoglobinuria. Other what imaging we can do, like chest radiograph, because person can also have pulmonary edema. ECG, obtaining any patient of electrolyte abnormality, because if we diagnose a patient of heat stroke, we would like to supplement fluid. While we are giving the fluid, we have to consider what is the cardiac activity of the patient. They may show the sinus tachycardia, conduction abnormalities can occur, QT prolongation, non-specific ST, or the patient can have this underlying CAD. So we have to look all those things into the account. NCCT brain required to rule out other causes of ultrasensorium like stroke, any SOL, any seizure like anything like infections. So we have to rule it out and NCCT. So these are the differential diagnosis of heat stroke patient. Infections are the foremost like sepsis syndrome, meningitis, encephalitis, malaria, typhoid, tetanus. All these are very common. Endocrine like thyroid storm or the pheochromocytoma, diabetic ketoacidosis, neurologic, hypothalamic bleeding or infarct, cerebrovascular accidents and status epilepticus, toxicologic, anticholinergic toxidromes, sympathomimetics overdose, salicylate overdose, serotonin syndrome, malignant hyperthermia, neuroleptic malignant syndromes, or withdrawal syndromes like alcohol or benzodiazepines. So all these we have to consider. So what pre-hospital management we can give? Time is very critical. Cooling must be initiated before or simultaneously with the EMS arrival. We have to remove the person from the heat, immediately remove from the source of heat stress. Put the ice packs, apply the ice packs to the neck, groin, axilla, place the wet cloths and the sheet on the patient and evaporate cooling. Remove cooling spray with the water fans to the provide airflow. Cold water immersion, there is a hot tub and we can put ice into them and we can put the person into them to decrease the body temperature. Hospital management, after when the person arrived to the hospital, we have to take care of airway, breathing and circulation. Careful assessment and support is needed. Patient may require intubation, especially the heat stroke patients. We have to take care of dehydration and volume. We can give isotonic crystalloid like normal saline, 250 to 500 ml bolus, and we have to uh, we have when we give the fluids because make the person the risk of pulmonary edema too. Hyperthermia, aggressively manage the initial rapid cooling immediately. Persons can have DIC, disseminated intravascular coagulation. We have to monitor the ventilation parameters, we may have to supplement with the free frozen plasma and platelets. Rhabdomyolysis can also occur. Monitor CK level, urine myoglobin level, and the maintain output. For altered mental status, give oxygenation, tissue perfusion, and the normotherapy. What are the rapid cooling methods? Spray tepid water on the patient along with the use of high flow fans. मतलब आपने पानी एक पूरे जिसे कहते हैं जो ओढ़ने की चादर होती है उसको पानी में डुबो दिया और उससे पूरे बॉडी पे आपने ऐसे वो किया. वट एग्जैक्टली इन मैनी हॉस्पिटल्स व्हाट इज हैपनिंग कि एक रुमाल जैसी चीज में या गॉज पीस में पानी से किया और माथे पे रख दिया बस. दैट शुड नॉट बी द वे ऑफ रैपिड कूलिंग. आपको पूरे कपड़े ढीले कर देने हैं. एक जो चादर होती है उसको पूरा गीला कर देना है. अगर आपके पास मतलब कोल्ड सलाइन टब नहीं है तो अदरवाइज यू हैव टू पुट द पेशेंट इन द कोल्ड सलाइन टब जिसमें आइस पैक्स हो और कोल्ड वाटर हो. उसमें आपको पेशेंट को डाल देना है. और अगर नहीं कर सकते हैं तो चादर को पूरी तरह से भिंगा के पेशेंट के ऊपर एक बार फिराया. व्हेन इट बिकम ड्राई देन अगेन उसके ऊपर हमने वो चादर रखी. सो दैट इज हाउ वी हैव टू डू द रैपिड कूलिंग. Cooling rate should be 0.15 degrees centigrade per minute. Add the ice packs to the neck, axilla, groin for the additional benefit. Cold water immersion use when the evaporative cooling is not possible. Undressed patient is placed into the tub of ice deep enough to cover trunk and the extremities while keeping the patient's head out of the water. Highly effective होता है when it is for especially for the exertional heat strokes. लिमिटेशन क्या है इसकी? शिवरिंग हो सकती है, डिस्प्लेसमेंट ऑफ द मॉनिटर लीड्स हो सकती है, इनएबिलिटी टू परफॉर्म डिफिब्रिलेशन इन द रिससिटेटिव मेजर्स इफ द पर्सन बिकम कार्डियक अरेस्ट. Internal or invasive cooling like cardiopulmonary bypass most effective but it is limitedly available. Intravascular cooling catheters होते हैं. Gastric rectal on the bladder लवाज कर सकते हैं आप cold isotonic NS से. So these are the summary. Evaporative cooling की like provide effective cooling, readily available होता है, practical है and well tolerated, can cause shivering, less effective in humid environment like in the coastal regions, makes it difficult to maintain electrode positions, and it is strongly recommended. Immersion cooling, it provides effective cooling, can cause shivering, poorly tolerated, and not compatible with the resuscitation settings. Ice packs to neck, axilla, and the groin. It is practical, can be added to the other cooling methods. Cooling time is longer than the other modalities. Poorly tolerated, can be used as an adjunct. Cardiopulmonary bypass, it is limitedly available, but it provides fast and effective cooling. It is invasive and not readily available. Cooling blankets, it is easy to apply and have limited cooling efficacy, impede use of other cooling methods. Not recommended when other methods are available. But unfortunately or fortunately, but mostly we are available with the cooling blankets and the these ice packs on the neck axilla. Cold water, gastric and the urinary bladder, rectal and the peritoneal lavage. It is advocate to cool core when cardiopulmonary bypass is not desirable or possible. However, efficacy is not validated. It is labor intensive and may lead to water intoxication. The pharmacological therapy the ma'am is going to discuss, I will take a small bite of this. Important is antipyretic medications are ineffective in the heat stroke, hyperthermia, and should not be used as they may exacerbate liver injury and compound coagulation. What we can give when we are managing that critically ill patient like midazolam for like seizures, or if we are to keep the patient on the ventilator, we can use midazolam or lorazepam. Complications of heat stroke, what can happen? So respiratory failure, most patients developing respiratory failure may require intubation and mechanical ventilation. Hypotension, peripheral vasodilatation plus cardiac dysfunction, and volume depletion. Treat with isotonic saline NS 250 to 500 ml boluses. Avoid excessive fluid IV in view of risk of pulmonary edema. Acute kidney injury can occur. You have to monitor KFT and the renal replacement therapy may be needed. Cardiac dysfunction can occur like sinus tachycardia, QT prolongation due to dyselectrolytemia, conduction abnormalities, transient Brugada pattern, non-specific T changes, resolves with cooling. Seizures is one of the foremost condition which we encounter also. We can use midazolam and lorazepam. Hepatic injuries, usually self-limiting, rarely may progress to the acute liver failure. Neurological complications, permanent neurological damage is more commonly seen in patients with a core body temperature of more than 42, 42, or we can say 107.6. Spasticity, ataxia, dysarthria, poor coordination, impaired memory, and behavioral changes can occur. Disseminated intravascular coagulation, that is coagulopathies, can occur. This can develop during the first 3 days of the heat stroke. We have to monitor for PT, APTT, and platelet count closely. We have to replace them by febrile plasma or a platelet transfusion. The early recognition is the crux. If we recognize it early, then we can prevent it further damage. Now a little word about the high heat health actions at the PHC level. What a PHC person can do. What as a healthcare person I can do at the society level. Early recognition is very important. If you encounter any elderly in your neighborhood who is a little bit disoriented, not able to take his food or her food, not able to do his daily activity recently during the summers, so you have to advise them or their caretakers to give them proper food, proper water, or cooling, or proper amount of fluid, proper amount of electrolytes, or ORS, oral hydrations, or cooling, and the refill triggers. So what are the emergency action cards when the suspected heat stroke? Immediate steps, we have to recognize it. So this we have done. Sorry. So if a management of this flow diagram is taken from the ministry guidelines. Suspected case of heat stroke, we have to call 112. Bring the victim to the safe, cool, and a shady environment. Take vital signs. Provide oxygen supplementation. Do not give any fluid or food if the person is unconscious or has altered sensorium. Otherwise, they may aspirate it or the further complications can occur. Remove all unnecessary clothings. Start tepid sponging. Increase airflow to the person using mist fan, spraying of cool water over the body. Apply cold compresses, ice packs at the neck, axilla, groin, and head. If possible, start IV drip infusion of cold saline. Check vital signs, monitor body core temperature, refer or transfer to the nearest appropriate hospital. So now let's look how to save the person's life by remedials, the small remedials. Stay away from the direct sun exposure from about 10 to 4. आपने देखा होगा कई बार क्या होता है, स्कूलों की छुट्टी हो जाती है कि बच्चे इस टाइम पर स्कूल ना जाएं. Avoid exercise during the hottest part of the day. Acclimate to the hot conditions slowly. Keep your house cool. Use coolers or the air conditions if the temperature is very high. Drink plenty of fluids. Wear sunscreen. Wear light colored clothes. Loose clothing and sunglasses. Preferably do not use any synthetic garments and tight garments. नेवर लीव एनीवन इन दी पार्क्ड कार. ये बहुत ज़्यादा होता है. कई बार ऐसे इंसिडेंट्स हैं हमें देखने को मिले हैं कि बच्चों को कार में छोड़ गए और कुछ सामान लेने गए और आप आधा घंटे तक बच्चा वो गर्म क्योंकि आप बंद करके जाते हो गाड़ी को और अंदर अंदर से जो कार होती है पूरी भट्टी हो चुकी होती है. तो मोस्टली दैट कैन हार्म द लाइफ ऑफ चिल्ड्रंस. टेक कूल शावर्स. ईट लाइट फूड. लाइट फूड का मतलब होता है फ्रूट्स अच्छे से अच्छे लें जिसमें वाटर की मात्रा ज़्यादा से ज़्यादा हो. बहुत हमारे जो लोकल फूड्स होते हैं वो बहुत रिच होते हैं मिनरल्स में और वाटर कंटेंट में. लाइक मैं अगर अपने बिहार की ही बात करूं तो सत्तू हो गया, चिड़वा हो गया, दही हो गया. सो ऑल दोज जो देसी खाना है हमारा वो बहुत रिच है इस चीज़ में. टेक प्रिकॉशंस विथ मेडिकेशंस एंड स्टे इन्फॉर्म्ड. अगर आपको कोई दिक्कत लगती है तो अपने आसपास के लोगों को बताएं और उनसे हेल्प लेने में बिल्कुल भी ना शर्माएं। दस व्हाट आई हैव डिस्कस्ड, ओआरएस, इसको इसका मिलना भी बहुत आसान है और इसको बनाना भी बहुत आसान है। हर एक मेडिकल शॉप पे मिल जाता है, इट इज़ वेरी चीप। कुछ पीएससीज में तो मेरे ख्याल से ये फ्री ऑफ कॉस्ट मिलता है। बनाना है 2 चुटकी नमक, 1 टेबल स्पून चीनी, पानी और थोड़ा सा नींबू अगर हो सके तो। ये बना के आप पिलाते रहिए, कोई दिक्कत नहीं होगी। यूज कॉटन क्लोथ्स ओवर द हेड एंड द फेस। ड्रिंक वाटर रेगुलरली। दोज हु वर्क आउटडोर स्प्रिंकल वाटर एट टाइम टू टाइम ओवर फेस। हम जो कहते हैं कि पानी से मुंह धो लिया करें। ड्रिंक वाटर रेगुलरली एंड हैव देयर मील्स प्रॉपरली। फ्रूट्स लाइक कुकुम्बर, जो गर्मी के हिसाब के मौसम के फ्रूट्स हैं, सैलड्स हैं, ककड़ी, खीरा, वाटरमेलन, सत्तू, चिड़वा, कर्ड, कोकोनट वाटर, शिकंजी, बटर मिल्क, all these are readily available. These are not very expensive. So we should make them aware, make the society aware of this, and we should use all of these things. When to refer, this is one of the important things. From PHC to the higher center, कब हम refer करें? जबकि हमें लगे कि जो इंसान हमें दिखाने आया है उसका रिफ्यूजल टू फीड है, ही इज नॉट एबल टू टेक एनीथिंग प्रॉपरली, एक्सेसिव इरिटेबिलिटी है, मतलब उसको सीएनएस सिम्टम्स कुछ आ रहे हैं, डिक्रीज यूरिन आउटपुट हो रहा है, ड्राई ओरल म्यूकोजा है, एब्सेंस ऑफ टीयर और संकेन आइज हैं, लिथार्जी, अल्टर सेंसोरियम है, सीजर्स हो रहे हैं या ब्लीडिंग फ्रॉम एनी साइड, seek the immediate medical help. So all these are the red flag signs. So if any of these is found in your consultation at the PSC level, please refer them immediately to the district level hospital or the tertiary care hospital. So these are all about from my side. These are the suggested readings. The important thing which I can say that NCDC के जो guidelines हैं recently 2021 की, very beautifully explained. Key takeaway is heat stroke is defined when the core body temperature is more than 40 degrees centigrade and the CNS along with the CNS dysfunction. Treat it as a medical emergency. Cooling is the most important and intervention. Begin immediately. Every minute of hypothermia worsens the outcome. Antipyretics are contraindicated in the heat stroke because they may worsen the liver failure. Acclimatization significantly reduces the risk. Ensure 7 to 14 days of gradual exposure. High-risk groups like elderly, children, those on medications require proactive monitoring. DIC, renal failure, hepatic injury, and permanent neurological damage are serious complications to monitor. So thank you. In the heat of the moment, the knowledge saves the life. So this is all about from my side. If any question or sharing of opinion hai, so please,
Dr. Devendu,
you
yeah,
are most welcome.
thank you. Will you be staying or leaving?
Ma'am, I am staying for about 10-15 minutes.
Okay.
I am staying.
Okay. Then in the meanwhile, if you have any questions, friends, you can write in the chat box. He can address this because he's traveling. He has to leave the session. The drugs treatment part and other things I will be taking over. You can direct your questions to the diagnosis and the overall management precautions to be taken in heat stroke. There is one question about sunscreen lotions are really helpful in preventing body loss of from heat or only for preventing from skin burn. Indication purpose served by the sunscreen lotions.
So, lotions are very if we are going in these direct sunlight, the sunscreens are really very effective. So if you are going directly into the sun on this and at the daytime, yes, you should use the sunscreens.
I think the main purpose is to protect from sunburns. It has
Yes.
nothing to do with the heat loss. Does it have? I don't think so. It has anything to do with the heat loss. Hello.
Sir, please stop sharing.
Then there is another question on Dr. Dwendu.
Yes,
Chest
ma'am.
sponging is to be done or not? Sponging. This is related to sponging.
Sponging should be done, ma'am.
No, chest sponging. He's asking about chest sponging.
So, in a patient of heat stroke, if the as I have explained कि पूरा आप तौलिया को लें, अगर बच्चे खास तौर से हम देखते हैं कि हम सिर्फ माथे माथे पे लगा के रह जाते हैं, तो वो नहीं करना है। पूरा तौलिया लें, उसको भिंगाएं और पूरा सर से लेकर पैर तक उसका पोंछ दें। फिर वो जो पानी इवेपोरेट हो जाता है, फिर आप सुबह ऊपर से लेके नीचे करें और बोथ साइड करें। ये नहीं कि सिर्फ माथे माथे पे करना है और चेस्ट को नहीं करना है। वी हैव टू डू completely from head to toe.
Yeah, this
That is
is
the
very
classical.
common, misconception. Don't follow movies. In movies they just show you, small piece of gauze,
Yes, yes,
put
yes.
on the forehead. That will not take care, and that too with ice cold water will in fact increase the body temperature because it blocks it makes vasoconstriction, and then heat loss is prevented. So the whole body needs to be, sponged, or best would be actually, if you can go, if the patient can go and wash, head, face, hands, feet with the running water. That would be even faster cooling than the sponging, but it depends on the discomfort that the patient has and whatever patient tolerates about this. There is one question about
Somebody has asked that the immersion in the ice water may prove counterproductive. Let me tell you, that is the treatment for the heat stroke only. है ना?
yeah.
वो हीट एग्जॉशन के लिए नहीं। जब वो कर सकता है तो वो करे, लेकिन अगर आपको हीट स्ट्रोक लग रहा है तो दैट इज द टाइम दैट वी हैव टू रिड्यूस द बॉडी टेम्परेचर एट एनी कॉस्ट।
And this is all graded, stepwise, not that
यस,
as a first
यस,
time you will put the
हाँ,
patient in the ice water for this. This
यस,
is
यस।
only when the patient is not responding, and there are a patient is in ICU or other things are happening, the body is not cooling, then only you will go for this. What is the earliest predictor of poor outcome in heat stroke?
Liver injury. Liver injury is the first poor marker, and another is the hematocrit. If there is a rising in the hematocrit, then it is the one of the earliest marker of the poor outcome.
So we need to avoid liver injury as far as possible. And
Yes,
I think the most common reason is antipyretic paracetamol
yes,
here,
yes,
because
yes,
people
yes.
rely on, they think fever means paracetamol and they keep giving it. Even in heat stroke, it is not going to work. And even if it is ordinary fever, there are doses recommended per day, maximum dose for
1
paracetamol
gram.
recommended. So not more than 500 milligram 6 hourly, 4 doses in a day. If you exceed that dose, liver injury is quite likely. And also, mind you, there are lots of fixed dose combinations which have paracetamol as one of the ingredients. So,
Hmm.
many times,
Paracetamol along with the acid like ibuprofen. So those
yeah.
things has to be avoided. Yes,
So
yes.
you need to avoid that. These are common mistakes in the management of even ordinary fever. Leave aside this heat stroke here. Okay. Then there is a question about laboratory parameter which is strongly associated with mortality.
Laboratory parameter which is strongly associated with the which is strongly it is liver injuries again, SGOT, SGPT, and creatinine level.
Again, the liver functioning
So
parameter.
yes,
Kidney, I think both kidney and liver function.
madam, what we I can say in the 2024 in 2024 we published the data of around 43 patients which come to the emergency of the AIMS Patna, and of this heat stroke was around 12 patients of heat stroke. Only 3 patients survived. Only 3 patients survived. So it is a very bad thing. Like, it is have a very poor prognostication. If the liver and the kidney has shut down, it is almost uh, impossible to return back. Along with it, because CNS is already gone. Now liver and the kidneys is gone. It is something which is very poor outcome is there.
what do you think this kind of situation, particularly at a tertiary care referral center at AIMS, could be prevented? Why do you
Ma'am,
think
I still think
in that
if it
condition?
happens, it is very. We don't have any antidote or anything like we can do and after happening, because it is a vicious circle. So the why we are doing this online program to increase the awareness, because prevention is the crux. आपको हीट एग्जॉशन से हीट स्ट्रोक तक का सफर नहीं तय करने देना है उन्हें। आपको हीट एग्जॉशन, मैक्सिमम हीट एग्जॉशन तक ही रोक देना है। जितना हीट स्ट्रोक पे जाएगा उसका आउटकम वी डोंट हैव एनीथिंग इन दी एनी एंटीडोट लाइक थिंग कि भाई आएगा और मैं ये दूंगा और वो ठीक हो जाएगा। इट इज अ सपोर्टिव केयर विच मैटर्स
So
इवन इन दी।
early, that means early referral is very important.
Yes,
Stabilization of
yes.
the
If
patient.
anything,
Uh,
anyone doubts about this की altered mental status है, dizziness है, patient is not confused है, so he has they should be referred to the higher center like DH or the tertiary care centers. Yes, ma'am.
so a referral, recognizing that it could be heat stroke or heat exhaustion.
Yes, that
That
is
is
very important. In our study, around 80% of them are elderly beyond 60 to 65 year of old. उनका मुश्किल ये है कि एक तो मुझे लगता है कि कल्चरली हमारा ऐसा है ना कि जो एल्डरली होते हैं वो कहते हैं कि एसी में रहेंगे तो ठंडा लग जाएगा। बड़ा मुश्किल है, मतलब दिस इज समथिंग बड़ा मुश्किल होता है। मतलब घर में एसी भी लगा हुआ है, बच्चों ने एसी लगा भी रखा है, दे डोंट यूज इट डिस्पाइट दिस हॉट टेम्परेचर। तो ये चीज मैंने देखी, और लोग कुछ थोड़े से वो होते हैं कि हाँ हमें ये यूज नहीं करना, हमें थोड़ा सा खाना पीना कम रखना है, फास्टिंग बहुत होती है हमारे एरिया में, लोग हर एक दूसरे दिन
they're
फास्टिंग।
building stamina.
नहीं
You're trying to prove that you can tolerate heat as well. Anyway, what is the critical time? Golden time period. Somebody has put that question. I was about to ask you that.
if in the case of elderly and the kids, if your kid or the elderly is taking meals, that is very good. If they just stop taking meals, they skipping meals, नहीं खा रहे हैं ठीक से, वो एक टाइम है जब आपको पकड़ लेना है उसको कि भैया डॉक्टर को दिखा ले कि क्या कर सकते हैं। आईवी फ्लूइड एक आध दिन चलेगा, शायद ठीक हो जाए, क्योंकि इफ दे स्टॉप टेकिंग द फ्लूइड, the major electrolyte imbalances and the body fluid imbalances occur, and the person land up into the multi-organ failure, especially the kidney failure. That is the something which is critical for the life. आई थिंक जब खाना पीना अगर आपको लगे कि भाई गर्मी की वजह से ये ठीक से खा पी नहीं पा रहे हैं, प्लीज कंसल्ट योर डॉक्टर, प्लीज कंसल्ट।
Okay, then there is another question. How long does cooling need to be done in heat stroke?
So the temperature has to be lowered down as fast as possible, and it within the 24 hour or how long until, because thermoregulatory setup is disturbed. So when you lower down the temperature, it will again go up. So if it goes up again, you have to bring it down again and again. So it
So
will
that
it will
means
take.
monitoring is also very important. Bringing
Yes,
it down to 39 degrees centigrade is the first target, that you bring it down to 39 degrees centigrade and then maintain it, or bring it to normal. Do keep monitoring, because it may rebound again, because till that time that thermo set is start functioning again, it may go up again.
yes.
So please don't think that once you have brought it down, the story is okay. You need to
No, no,
monitor.
no, no.
Okay, I think that answers. The temperature has to, target temperature is 39. Am I right, Dr.
Yes,
Diven?
yes, okay.
Yeah.
Yes, ma'am.
Okay, I think. Okay, I have one question.
Yes, ma'am.
You said, it differential. Whenever there is a fever, then it could be malaria, it could be dengue, and particularly in a season like this, where a place like Delhi or malaria, dengue, heat stroke can all be there. So what is the priority, or how, diagnosis of, you will send the sample for dengue or malaria by the time report comes. What is the priority management here for this?
So, ma'am, if someone reach to our casualty with all these symptoms of high body temperature along with altered mental status, we will keep the diagnosis of heat stroke, but along with it, we also consider it as a meningitis, as a cerebral malaria. So we give empirical treatment for this. Yes, we cover with the antibiotics, anti-malarials, because every second counts. For heat stroke, we have only supportive management that is also continuing along with the this. And what we have to take in our history taking, what मेडिकल साइंस में कहते हैं ना, हिस्ट्री टेकिंग इज एन आर्ट. तो आपको उसका बैकग्राउंड देखना है कि क्यों एक आदमी जो अकेले घर पे रहता है, जो क्या होता है हमारे मोस्ट ऑफ द सोसाइटीज में आजकल क्या है, मदर फादर दोनों अकेले हैं, 70 ईयर्स के हैं, वही देख रेख कर रहे होते हैं एक दूसरे की. अब गर्मी आ गई है, उन्होंने खाना पीना छोड़ दिया है और 2 दिन से बाबा जी बोल नहीं रहे. सो वी हैव टू टेक द बैकग्राउंड कि ये ऐसे बैकग्राउंड में उनको मेनिंजाइटिस तो नहीं हो सकती है. घर आजकल अच्छे होते हैं, वहां पर मच्छर वच्छर तो होते नहीं है मैडम. अगर वो इस तरह के एरिया से नहीं आ रहा है, yes we keep the diagnosis of malaria, we give them anti-malaria, but once the report come negative we cut off the anti-malarials. हम वो भी रखते हैं, लेकिन उसको फिर we can downgrade it and then we can make it. ये तो हीट स्ट्रोक है. सो क्योंकि अगर ये मलेरिया अगर हमने मिस कर दिया, देन इट इज आल्सो ए वी आर मेकिंग ब्लंडर्स. सो एम्पेरिकल ट्रीटमेंट में एज मच एज वी कैन कवर टू सेव द लाइफ. लेकिन जैसे रिपोर्ट आती जाती है, वी हैव टू कट ऑफ और डाउनग्रेड आवर, वी हैव टू कस्टमाइज आवर ट्रीटमेंट फॉर आवर फाइनल डायग्नोसिस.
But I believe cooling remains the priority.
Same. Yes, yes,
You have to do both. You have
both
to
the thing.
take history, do the differential, and give whatever, if you presumptive, if you think that it could be malaria or whatever, you give treatment for that, but cooling remains the priority. So don't
Yes, yes.
defer
So
cooling
that
for
is, हाँ,
confirmation of
ऐसा
attack.
ऐसा नहीं है कि मलेरिया का बुखार होगा तो हम उसे कूलिंग नहीं
Yeah.
करेंगे.
Many times people, I was going through the pre-test, the answers. I must congratulate today's participants. The score is very good. The average score is about above 16. So that's really very good. But few, people had these, myths or misconceptions. So I thought, let me just cover this in the session so that it becomes the 100%. The
नहीं.
post test becomes the score becomes the 100%.
Yeah, I gone through your actually questions. You have very well crafted those clinical questions. Actually, those are questions are very good. मतलब वो होते ही हैं. वैसे actually scenarios मिलते ही हैं हमें day to day life में. So congratulations, ma'am, that you have done this
Thank
very
you.
good.
One more question. I will be dealing with the drugs for this. How frequently do you think that this heat stroke was precipitated by the medicines? These elderly also taking, they have comorbidities and they are on lots of medications. So how, what proportion of your patient, this was the problem?
Madam, this can happen. This can happen. मतलब this is nothing like कि ये हो नहीं सकता.
Okay.
ये नहीं है. ये मैं कह सकता हूँ कि ये हो नहीं सकता. But again, you have to think about the scenario. In which scenario this happens? अगर
So
इसमें drug की history है तो yes, it can happen.
so
ऐसा हमने
must
देखा है. Yes.
don't take it lightly. You must
No,
keep
no.
this option
Yes, yes.
very much there.
Neuro,
And
neuroleptic malignant syndrome, yes, come in the diagnosis of heat stroke many times.
so when do you think is the indication for dentroline? That was the most wrongly performed question.
Actually, madam, if the diagnosis is confirmed, then we can use it.
Okay.
I personally have not used it till now. I have seen many patients, but I have not used it till now.
Okay. From the responses, it appeared that people use this dentroline as the one of the common option. So which I thought was not that common.
No, it is, yeah, exactly. So neuroleptic malignant syndrome is the differential diagnosis of the heat stroke. So if it is heat stroke, you don't have to use dentoline. But if your diagnosis is NEM, then you can.
So again, careful history will help here.
Yes, yes.
Thank you, Dr. Divendu, for
Thank you, ma'am.
coming and
Thank
sharing
you,
your
ma'am.
experiences. I hope the audience found it useful. Now, I think people are waiting for the post test. Anyway, they think that they know it already, but I think I'll, take this pharmacology part, and you would like it. I have, done it in a different way, not in a traditional classic pharmacological teaching. I hope it will be beneficial. We'll do the, test later. Hold on for some time. Can you see my screen?
Yes, ma'am.
Okay, I'll go to the full slide mode. We'll do it quickly. Some of it would be recapitulation, but I think it is worth doing it. So practical pharmacology decisions here in heat stroke start at the bedside. You have to recognition of this heat stroke fast is very, very important, because there could be mimics of this heat stroke, such as sepsis, drug-induced hyperthermia syndromes. These may be there, but you have to recognize that this is heat stroke fast, and prioritize rapid active cooling. That is the priority. Fever, when it is beyond these thresholds, the priority is rapid active cooling. ABC and monitoring before low value medicines or investigation is very important here. So ABC, like for any other resuscitation, this is also an emergency. This is called every minute. If you delay cooling, it will result in loss of tissue. So time loss is the tissue lost here. Like in case of stroke, we say time lost is brain lost. Here you are losing on tissue, liver, and the kidney tissue dysfunction. So it is very important to act fast and prescribe safely. Use fluids, benzodiazepines, vasopressors rationally, while avoiding antipyretics, NSAIDs, and nephrotoxins here. I think I can skip this. Uh, uh, there is no first drug. First drug is cooling immediately, whereas reflexly we start with paracetamol. In case of heat stroke, that is not the first. So move to the cool area, clothing, start active cooling, check ABC, glucose, core temperature, IV excess fluids. Without delaying, cooling is the most important step here. So the difference, the heat stroke is not ordinary fever, and antipyretics will fail here and will add actually to the poor prognosis. In fever, hypothalamic set point rises here. So whereas antipyretic may help because prostaglandin pathways are involved. So in uh, inflammatory fever could be because of the inflammation. So antipyretics are helpful. But heat stroke, I think you all must now learn that the thermoregulation fails. Heat production and heat load, they exceed the heat loss. So treatment is physical heat removal. So do not use paracetamol, aspirin, or NSAIDs as temperature treatment here in case of heat stroke. So any patient, you recognize, diagnose this clinical. This is a clinical diagnosis. Any patient suspected heat stroke with hyperthermia, with CNS dysfunction, follows heat exposure or exertion, treat them as heat, and you need cooling while evaluating. So it is not a lab diagnosis. Please remember that it is a syndrome. So you need to recognize the CNS flags here. Any of these symptoms, confusion, agitation, delirium, seizures, coma, all these may develop. Or physiological clues here could be the body temperature rises above 40 degree, 104 degree Fahrenheit, tachycardia, hypertension, hot skin, sweating may be present or absent. So these are the physiological clues. And complications that you should anticipate are rhabdomyolysis because of the cramps, the muscle injury, acute kidney injury, hyperkalemia because of this muscle injury, hyperkalemia happens, hypoglycemia, hepatic injury, DIC, and acute respiratory syndrome. So do not wait for the labs. Do not for the creatinine kinase, creatinine or LFT. Start cooling the patient. So there are many wrong practices here. If we are sending the patient for referral before starting cooling, it is like, your car engine is hot and you send this car on the highway, so it will get hotter on the way. So before you refer these patients, start cooling this. So because this ongoing hyperthermia continues, organ damage will happen during transport. So spending time on paperwork, scans, or multiple blood tests before cooling, again, this is like, firemen who have come to fight with fire, and if they start doing the paperwork, what could be the situation. So similar situation, here you need to save the patient. You do necessary tasks which prevents harm. So this is the most important. Cooling is the most important life-saving step here. And many times people deeply sedate agitated patients without airway planning. Sedations, I will come to the indications for sedations. When do you need it? Sometimes because of the excessive shivering, or seizures because of the heat stroke, benzodiazepines are given, but a small dose is enough. You don't have to over sedate these patients. So don't give large doses, or don't give these benzodiazepines repeatedly here. So then again, another wrong practice is giving NSAIDs in a dehydrated patients with rhabdomyolysis link. Risk here. The patient is, this bridge is already cracking. The bridge is weak, and if you give NSAIDs here, because the patient is already dehydrated, it can lead to renal injury and increases the bleeding risk in these patients. And of course, continuing some of these drugs like lithium, diuretics, ACE inhibitors, ARBs, or nephrotoxins, despite AKI or dehydration. Most of the time, if you look for the reason for acute kidney injury, it is the medicines, only. It is iatrogenic, induced by our management here. And if we don't recognize this fact, we continue those nephrotoxins, and the kidney failure or the damage increases. So you need to review the medicines regularly, in otherwise also, but here in heat stroke, they are catastrophic if we don't review. Assuming one diagnosis only and missing drug-induced hyperthermia syndromes, that is another option. NMS, serotonin syndrome, these malignant hyperthermia on volatile anesthetic agent, they give different clues, and their responses are different, so you need to recognize that. So cooling is I think I'm repeating this, but this is very much important. Cooling is the life-saving intervention, and it must never delay heat removal. So best possible, use cold water or ice water immersion. Common options that we have, Dr. Divendu has already talked about it. Cool to about less than 39 degrees centigrade as quickly as possible, ideally within 30 minutes of recognition. Then stop active cooling and monitor for rebound for this patient. So he was talking about placing ice packs on these uh, forehead, uh, neck, and groin area, because there are large vessels here. there is a lot of amount of heat is lost through this, and these ice packs cool these blood here, and then this cool blood is carried to the entire body. That's how these help. So there are situations when which method would be used, and one must know how do they work and how can we put it to use in practice. So evaporative cooling is the first line. You give cool water spraying, sponge on skin, fan, clothing, all that is cheap, available, but it is less effective in high humidity, so it requires a continuous airflow. So it will work continuously if we multiple fans, remove clothing, continuously wet skin. He was telling you about you wet the bed sheet, and put it on the patient. Then ice packs, this will help if these are rapidly available, easy during transport, especially when you are transporting these patients, use these ice packs. They are insufficient alone for severe heat stroke, but skin of risk injury is there, but you don't put them directly, put something in between. But this can be used as an adjunct while arranging more effective cooling. So till that time nothing is available, you can use this ice pack. Cooling blankets, they are useful in ICU or in emergency setting. It allows continuous temperature control. Limitation is that it's slow, the cooling is slower than the immersion or evaporative methods, but it could be best combined with other cooling techniques. Chilled IV saline, this also can be used as an adjunct. This is an internal cooling plus volume resuscitation, very useful in patients who are dehydrated, who have hypotension, and during transport phase, this can be used. Has a limited effect, but it corrects the dehydration and hypotension part, may cause shivering or fluid overload. Then you have to titrate these crystalloids when you are giving the rate and how much you will give. So this is not a primary cooling method, it is just a supportive therapy. So paracetamol, no here, common. So don't use this. This is not a this is cooling prescription, because aspirin and these things can cause liver injury, and rhabdomyolysis, AKI, all these things are very common. Tepid sponging in fever is the most important. It depends on, useful. This is a useful supportive care, but not a compulsory ritual. You have to see whether the patient is comfortable or not. Use lukewarm water, stop if uncomfortable. Routine sponging of a comfortable child, or cold water or ice, this is not needed. What matters more is assess for the danger signs, hydration level, age and duration of fever, source of infection, and correct antipyretic dosing is very important. So focus more on that. So fever practice, I think I have already covered. Alcohol is not advocated in stroke. It alcohol cools the skin, but it does not cools the crisis that the patient is having. So it cools the skin briefly, but does not provide safe, reliable core cooling here, because of the several reasons, because it has a toxicity risk, because of the skin absorption, and from vapor inhalation it can lead to altered sensorium, especially in children, elderly, or unconscious patients. So, and it also leads to constriction. Cold surface sensation can constrict skin vessels and reduce heat loss from the body. It can lead to shivering. So rapid surface cooling can increase muscle activity and thus increase the heat production. And of course, this is a flammable agent. It should avoid risk with oxygen around and other electrical equipment. So big no to alcohol sponging. So instead use cold or ice water emulsion, evaporative cooling adjuncts that I have already told you. Okay, then how, when do you switch to from sponging to active cooling? This is a practical sequence for emergency ICU and wards. Recognize heat exposure, CNS dysfunction, body temperature is high. Expose and move to cool area, that is the second. Cool large surface, body surface area. Immersion if possible. Spray, fan continuously. Add adjuncts during, especially during transport, and monitor and stop, as I told you. So don't wait for, you should start cooling within minutes of diagnosis, before labs and transfer of this patient. So I think I told you already about this. Benzodiazepines, regarding this, this may be needed because of seizures may happen in heat stroke. The patient may be severely agitated or may have shivering because of the cooling. So, but remember that this is not a cooling treatment. This is a treatment for management of seizures and agitation only, and sometimes excessive shivering because of the cooling. So cooling remains the process priority. Then it helps it because it stops muscle activity, reduces heat generation, improves safety of the patient. But there are few watch signals here. Must always see that there should not be any airway compromise. So ensure ABC first here, because if you deeply sedate the patient, the patient may not be able to recover because of this, this respiratory depression caused by these benzodiazepine and hypotension. So what should you be doing? Titrate small IV doses, like if you are treating first line seizures and for dangerous agitation, or which is adding to the heat generation. Don't use this for every heat stroke patient. It is not for every patient, and allows sedation to delay active cooling or airway assessment. So again, I think the core message here is this is not this is does not cool the body. It just controls the heat producing complications. So water, airway, rapid external lowering remains the mainstay of treatment here. So Dentroline, again, many times this mimics the heat stroke. These are different hyperthermia syndromes, malignant hyperthermia, or neuroleptic malignant syndrome, serotonin anticholinergic toxicity. So think they have, all of these have different pharmacology here, why the temperature is high. So we all know how the heat stroke happens. Malignant hyperthermia is triggered by volatile anesthetics or succinylcholine. So treatment here is dantrolene plus crisis protocol. Whereas in neuroleptic malignant syndrome or serotonin syndrome, think in terms of the drug history, neuromuscular signs, autonomic features, and medication exposures. So here, medication history is part of resuscitation. So what if you are cooling the body, and but the triggering medicines are continued, so if you don't control the source, the patient is not going to improve. So it is part of the resuscitation. Better warning signs are there. But again, here again, don't allow the full blown drug induced malignant hyperthermia to happen. Don't whenever this EtCO2 is rising, is just get or there is acidosis, there is rigidity, after trigger, this is a warning sign. So one must think in terms of drug-induced malignant hyperthermia, tachycardia, arrhythmia, generalized metabolic or respiratory acidosis, hyperkalemia, myoglobin, CK rise. So this hyperthermia may be late here. This is how you distinguish it from drug-induced malignant hyperthermia. So stop triggers, immediate management of drug-induced malignant hyperthermia is stop triggers, turn off vaporizers, stop succinylcholine, volatile agent, call for help, and look for these informed surgeon, prepare dantrolene, 100% oxygen is required, high flow oxygen, hyperventilate, change circuit, dantrolene IV are, this is the dose, repeat as needed until the crisis is controlled, and you need to prevent complications here. So suspect early, stop the triggers, start dantrolene without delay, and monitor for recrudescence for at least 24 hours in these patients. Fluid and electrolytes, and how do you protect the renal protection? This will support circulation without creating new harm. So initial fluid choice here is isotonic crystalloids when there is dehydration, hypotension, or rhabdomyolysis risk is present, and but you need to assess often. Don't overload the patient. Monitor core temperature, BP, vitals, creatinine, CK, and electrolytes, LFT, coagulation profile when the patients are on these fluids, and avoid extremes. Do not under resuscitate shocked patients. Do not blindly flood elderly heart failure or renal failure patients, because it can lead to fluid overload here. So rhabdomyolysis, we need to prevent this because this can convert a heat emergency into a renal emergency. So you need to avoid all those agents which can cause nephrotoxicity, avoid NSAIDs, contrast if possible, aminoglycosides, and other nephrotoxins in these patients. Now coming to differentiating, there are mimickers. Dr. Dwivendi mentioned about the heat stroke patient. They can have they can present as shock, or it may be differential could be infection or sepsis at first contact. So you need to ask these three questions here. Heat exposure, is it heat exposure or exertion? Is there poor perfusion or hypotension? Is there any infective source or organ dysfunction at the time of present first contact? So do not actually, again, while we are saying that do not wait for labs, if the patient has altered sensorium and dangerous hyperthermia, start cooling while resuscitating. But meanwhile, you need to differentiate. Could it be heat stroke, or is it the shock, or is it the infection sepsis? Because your priority for management will change. Heat stroke, rapid external cooling, and ABC remains your priority here. If it is a shock patient, in addition, you would need oxygen, IV excess fluids, and vasopressors by cause. And if it is the cause of this hyperthermia is infection or a sepsis, the priority here is that microbiological culture samples are drawn before giving any antimicrobials here. So again, they would also need fluids, plus source control is very important. So clinical caution here is these conditions can overlap. In the at the time of presentation, they may not be distinct, but later as you look for it, other signs and symptoms, you will pinpoint on a diagnosis, but treat the immediate life threatening physiology first, which is heat stroke. So cool severe hyperthermia, restore perfusion, and cover suspected sepsis after appropriate cultures when feasible. So you can look at other guidelines for management for do not the idea that I want to say the lactate in septic even uh, in sepsis there could be acute organ dysfunction, septic shock, and the lactates may rise. So you may use different clues, but treat the life-threatening physiology first before moving to this. So avoid these two treatment traps. Many a times we think that we have started with vasopressors and antibiotics, it will take care of it, the hyperthermia, but these have their own role, but their timing matters. So when do you give is very important. So do not use pressors as a substitute for heat removal. So that remains the priority. Cooling remains the priority. So these vasopressors are needed in stroke patient if hypotension develops, is persisting despite cooling, and cautious fluid and assessment for other causes of shock. So antibiotics do not automatically give for high temperature. Use if infection is clinically suspected. Okay, so these may look similar, but you need to use this. Then other medicines that can increase the risk of heat illnesses, especially look for ask for this in the drug history early, especially in older agents. So anticholinergic, they lead to rise in body temperature because they reduce sweating. Some of you had written in the pre-test that it increases sweating. It is, they reduce sweating and cause confusion. Beta blockers, they cause blunted cardiac responses here, so the presentation may be adaptation would be difficult. Antipsychotics, they interfere with the thermoregulations, and it is one of the NMS mimic, so you need to see to it because it can cause neuroleptic malignant syndrome. Lithium, it increases the toxicity of lithium. The excretion of lithium from the body decreases when there is dehydration. So lithium toxicity can happen in these patients. Diuretics, they cause dehydration and electrolyte disturbances. Topiramate and diazepam, again they reduce sweating. The ACE inhibitors and angiotensin receptor blockers, they increase the acute kidney injury risk during dehydration. So be careful about this. And stimulants, they cause heat production and agitation. So whenever you are planning for heat wave, review the prescription of the patients, especially the high risk patient, children and elderly. Counsel them, and if the hyperthermia develops, temporarily hold high risk medicine. This is a temporary holding only. They should not, you need for permanent holding, you need to consult and think about. If it is unnecessary, fine, but most of the time it would be required because elderly patients often have comorbid illnesses, so these medicines are needed. So when clinically appropriate, hold them. So and you need to restart these chronic medications deliberately, not automatically. You have to see whether the timing, when can you bring these back. So review, one is that at the time of the presentation that you review if the patient is receiving any of these medicines. Then once the patient is controlled, the body temperature is brought down, then again it is time to review medication and look for what is the harm by these, check organ functions, look for these drug induced hyperthermia, and plan discharge safety accordingly. So you must give heat avoidance advice, hydration plan, sick day rules, medication counseling, and follow-up labs if needed for this. So I think by this time it is all clear. We need to avoid, do not treat heat stroke like routine fever. Don't give paracetamol and NSAIDs repeatedly. Don't wait for lab results before cooling or using dentrolene reflexly. Over sedation without airway monitoring can be harmful for the patient, and blind large volume fluids in frail patients can lead to fluid overload. And if you miss this drug toxicity, especially lithium or anticholinergic, this will be very harmful, and stop these nephrotoxics immediately. So I think I'll skip this. Heat stroke, what medication safety checklist you can use in emergency or ICU or wards. First 15 minutes, you know, this could be your audit question as well. Whether the cooling started before medicines, whether the core temperature was monitored, rectal temperature, or paracetamol or NSAIDs were given or not given, seizures or agitations were treated safely or not, fluid reassessed after each bolus. This should happen within the first 15 minutes. Then first 24 hours, you can ask for the labs. You withhold nephrotoxins, high risk chronic medicines review, and drug induced, and restart and discharge plan documented or not. Documentation is anyway very important. So these are the worth remembering messages in a busy emergency. Heat stroke is a cooling emergency, not a fever emergency, so you have to treat it like that. So antipyretics do not treat heat stroke and may in fact cause harm. Benzodiazepines are an adjunct for seizures, agitation, or shivering, not a cooling drug. And fluid protects the resuscitation and kidney when it is guided by reassessment. Always review medicines that worsen heat risk. Or I think that's it there. So when in doubt, still cool the patient, monitor these patients, reassess, and remove medication related harms in these patients.
Wonderful talk, Dr. Sangeeta, ma'am. Capturing the most important elements, the essence of treatment. Don't use antibiotics to lower temperature. Don't use medicines to lower temperature. Don't wait for labs. The emergency is temperature. And I think a very timely reminder as well that referral is not the solution. The first thing is to start lowering the temperature and follow it up. Once you've done that, then follow it up with referral. Because as the analogy you gave, if the car is already hot, why are you putting it on the highway? Very important reminder that similarly, this is one of those common sense emergencies which can be treated with common sense. One doesn't have to rush in with medicines. Look at the temperature, look at bringing down the temperature. It's like bleeding, hemorrhage.
Yes.
Hemorrhage, the important thing is control the bleeding. Referral can follow, but control the bleeding. Pressure bandage could be a lifesaver. A simple IV line would help, but pressure bandage to control the bleeding is the most important treatment in an emergency. So keep these simple things in mind. Prevention is always better. Avoid the sun. What's happening outside, but if you have to go out, use hydration as a tool. Use the various methods to keep the sun away. And the next thing is recognizing that you have an emergency. I'll just give you an example. Someone called me last summer from Rajasthan, says, "वो भाई साहब बहुत जिद्दी हो गए हैं." His elder brother, he's 80 plus, says, "भाई साहब बहुत जिद्दी हो गए हैं, बुखार है लेकिन खाना कुछ नहीं खा रहे, सुस्त है, पड़े हुए हैं. He is very stubborn. He's not listening to me. He's not eating anything. I'm fed up." I said, rush. This is a danger sign. Don't think he's stubborn. This is a danger sign. Rush. And I'm very happy that rushing did help save a life that day. Recognize this thing that someone who is otherwise active is not behaving normally, will be going down very steeply. The downhill journey can be very steep, especially in children and elderly. Elderly, we tend to think that everything is just like a normal adult. No, the physiology has changed, the mechanisms have changed, the tolerance limits have changed. Uh, Uh, extreme heat, all these heat waves that we hear of, is a cause of a very significant cause of excess mortality, which we must understand. We all keep focusing on those fancy things, but heat stroke, heat exhaustion can be prevented by simple methods. And as Dr. Divendu was saying earlier, Sattu, Ampana, the traditional things, that gamcha that we're talking of, we are very proud to wear a hat, but a simple gamcha could be a life-saving thing. The simplest thing, a wet towel or a wet bed sheet, put it on the patient and run the fan. Evaporative cooling is more important than all those fancy things that we see in movies where a patient is picked up and dunked in a tub of ice. No, that's not what is required. What's required is evaporative cooling. The only limiting factor for that being high humidity, in which case other adjuncts may be required, because evaporative cooling, it's limited by high humidity. We see there are some questions, and I think the best anchor for these questions is Dr. Sangeeta. So over to you once again.
Are there questions?
I saw a couple of them. Let me just pull them out.
Okay. Need of antibiotic in just a minute. There was one question about antibiotics. Which one was this? I just saw. Can you? Do you see, Dr. Patni? I didn't see that
Let me
question.
just, let me just see this. I had seen one.
Yeah.
Someone asked, are sunscreen lotions really helpful?
Oh, that we
That
answered.
has been answered. Yeah, a similar question came up again. Cool water bath and all. Just a second.
वो सब वो हो गया था. अभी मेरे ख्याल एंटीबायोटिक वाला था कुछ क्वेश्चन. I saw it and then I don't know where it. Can you repeat
Ranjit,
that question? You can unmute and repeat your question if you somebody. I just can't see it here in the chat. You can write it again or unmute and ask this question.
There is one question. Can newborn baby get heat stroke?
Need of antibiotic in sterile blood culture patient. Investigation role in use of antibiotic. Please select above topic for discussion for the next time. Okay, we did have one session on antimicrobial stewardship. But some time back you can access that on the YouTube channel of NHSRC. All the previous sessions are uploaded on the YouTube. You can go through that session, and I definitely agree with you. Antimicrobial stewardship is one of the very important topics. We will consider this for the next series whenever possible.
So can I comment on this? Newborn
Yeah.
can get the heat stroke or not? So newborn can also a risk factor. So they can't speak. If you keep them in a warmer place and the breastfeeding is not adequate, mother's breast milk is not expressing it adequately. So those newborns are at risk of heat stroke too. Yes. Even they will not have fever. They will present with the sepsis also. So newborn is definitely a risk group for heat stroke.
Children, they cannot share their, tell you their problems. They depend on their parents. It depends on.
Many times, ma'am, last summer what happened in our city, there was a, मतलब paper में भी आया था कि बच्चे खेल रहे थे और खेल खेल में कार के अंदर बंद हो गए, छुपन छुपाई खेल रहे थे, और वो हीट का दिन था, वो हीट में बंद रह गए, दे कोलैप्स देयर ओनली. So it is unfortunate and it happens actually.
Yeah, very sad. Yeah. And these things are done, happen in ignorance.
In ignorance actually.
Heat stroke and sepsis treatment protocol, how to differentiate between them, common in infants and geriatric. I think I told you, I showed you that screen where you how to differentiate between heat stroke and sepsis and shock due to other reasons. Shall I show you? Maybe Dr. Divendu, you can address that question. How to differentiate from sepsis?
So heat stroke, definitely we have learned that a heat stroke is something where the temperature is more than 104 and the person is having altered mental status. It can mimic other infection, other sepsis too. So there, as we have to look up about the background, as ma'am has already said, कि ऐसा नहीं है कि गर्मियों में meningitis नहीं हो सकती, गर्मियों में मलेरिया नहीं हो सकता, बिल्कुल हो सकता है, लेकिन आपको देखना है कि क्या बैकग्राउंड क्या है उसका. अगर आपकी इमरजेंसी में सेप्सिस ऑब्लिक हीट स्ट्रोक का पेशेंट आया, आप स्टार्ट करो ट्रीटमेंट, आप एंटीबायोटिक दो. एज मैम सेड, एंटीबायोटिक से हीट स्ट्रोक ठीक नहीं होगा, लेकिन एंटीबायोटिक से अगर यूटीआई हुआ है उससे और उसकी वजह से वो है तो वो ठीक होगा. तो एम्पेरिकली एंड ब्रॉड स्पेक्ट्रम एंटीबायोटिक हम इसीलिए यूज करते हैं टू सेव द लाइफ अर्ली. व्हाट इज द कॉन्सेप्ट ऑफ गोल्डन आवर्स? दैट इज द थिंग. हम गोल्डन आवर्स में सेप्सिस के बंडल नहीं भूल सकते. हम एक घंटे के अंदर ये नहीं कह सकते कि हीट स्ट्रोक ही है. इट इज नॉट सेप्सिस. वी आर नॉट दैट मच, अभी तक हम इतना मेडिकल केयर आगे नहीं बढ़ पाए, तो हमें सबको कवर करके चलना है. लेकिन एज एन एज द पेशेंट प्रोग्रेसेस इन आवर हॉस्पिटल, तो वी हम देखेंगे. अगर नहीं है, सेप्सिस निकल के नहीं आता है, तो वी विल ट्रीट एज हीट स्ट्रोक. हम ऐसा तो है नहीं कि फीवर कम करना बंद नहीं करेंगे, फीवर भी हम उसको डिक्रीज करेंगे टेम्परेचर. वी विल डू ऑल दोस थिंग्स. तो
Only
हीट
the
स्ट्रोक का ट्रीटमेंट तो सपोर्टिव है बेसिकली. सपोर्टिव एंड अर्ली रिकॉग्निशन ऑफ द, ये कि आप उसको कहीं डीआईसी तो नहीं हो रहा है, कहीं अब उसे एलएफटी तो डिरेंज नहीं हो रहा है, जो वी हैव टू जस्ट कीप ऑन चेकिंग ऑल दोस थिंग्स.
So sepsis would have all these symptoms, hyperthermia will be there, shock would be there, organ dysfunction would be there. But here you need to look for the source of infection. So it could be urine infection, blood infection, respiratory infection. So depending on the good history here again, you will try to pinpoint what could be the source, and that is why we are not saying to withhold antibiotics here. We are just saying take the sample for microbiological testing before giving first dose of antibiotic. The reason for this is because even one single dose of antibiotics will render your culture sterile. So then the whole
Yes.
exercise will be futile and you will lose that time, because
Yes.
antibiotics will make the culture sterile, so you will not be able to identify the pathogen here, and you will not be able to switch to a targeted therapy. You started with a broad spectrum, but for targeted therapy you need to identify the pathogen here. So all that exercise will be useful if you draw just small intervention, you draw sample before giving first dose of antibiotics. Any other questions? I think we did finish today in time. Usually these sessions go beyond also, but I think time management was good today.
Dr. Ranjit.
ठीक है, post. I must tell you, many of the participants have got 20. 86 people out of 110 got 20 out of 20.
Yes.
So you can pat on your back.
Yes.
डॉक्टर पत्नी, आज 86 लोगों का 20 आया है.
Very happy to hear that. Very, very happy. Very pleased to see this. The session has been very effective, I'm sure. Yeah.
Pre-test में 54 out of 190, 200 got 20. So you see
And another thing that I noted was almost everyone who joined was there till the very end. They are still there. So even though they have finished their test, they are continuing with us. I think what's left now is Dr. Ranjit. Are we ready to close?
feedback form, Ranjit, please. I think feedback form नहीं दिया है.
I've already shared, ma'am, and they have submitted also.
No, I don't see any. Please do give us the feedback. We do, go through all these feedback, so it won't go waste. We will consider for before organizing other programs. What is this? Everyone wants to stay away from pharmacology. Pharmacology used to be a very dry subject.
Pharmacology is interesting, madam. Those who are interested in the medicine, I think their first love is pharmacology.
But अभी कोई लिखा था इधर, pharmacology क्या था? I don't know how am I missing those things. Are you writing these comments for the everyone or direct messages? Because I have opened the everyone's wala. Credit, you will get the credit hours. Ranjit, could we manage to get credit hours for this session?
No, ma'am, no credit hours. We have not
Okay.
been able to get it from games.
DMC was in elections and all that, a lot of things up and down are happening over there. So we could not get the credit hours for this session. But I think all of you are here for knowledge sake and improve our practices. That purpose is served.
Till 41st of STG session, we have already shared the certificates. For this session also, we'll share to the one eligible. But by next week, we will share to all.
Okay. This is about, everyone wants to stay away from pharmacology, but when you explain, it becomes interesting. Okay. Thank you very much. I just want you to request to revise even each antibiotics. No, I didn't get this question. Oh, antibiotic stewardship is a separate session in itself, actually. We'll do this sometime again. ACS and emergency webinar, not Ranjit, YouTube channel, is that updated?
Yes, ma'am. It is updated.
Dr. Sanjeev Puri is our very old friend and participant here. He never misses a single session.
Okay. But I'll check. Yesterday also we have said for the video of the 41st session. Just I'll check with our.
Okay, you share that link with me. I can share with Dr. Sanjeev Puri.
Okay. Okay.
I can pass it on to him. Okay, I think we. Oh, still there are questions. Okay. Thank you so much to these Dr. Dwendu, Dr. Patni for supporting, for wholehearted support for this program and encouragement that you give us every time when we have this session. Thank you, Dr. Ranjit, for making this happen. He puts all the things together in a timely manner. So making things. What is the next topic session?
Yes, ma'am. The next session will be on common ophthalmic problems, screening, initial management, and red flag reference, eye screening in primary care, red eye vision loss and diabetic retinopathy.
सारा ऑप्थेल्मोलॉजी कवर कर लिया क्या?
Basically for Ayushman Arogya Mandir, this topic is basically for to catch the CHO and the professionals who are working in the primary healthcare facilities.
Okay.
So it will be scheduled on 18th of July, the third Saturday, as usual, and same time.
Okay. Wish you all the best. See you in the next session.
Thank you, ma'am.
Okay.
Thank you, ma'am. Thank you. Thank you. Thank you, sir.
Uh,
I've shared the feedback link in the chat box.
abhi aa gaya. Now people have filled it.